Hello, I'm Dr. John Kruse, and welcome to today's question and answer hour. So I will attempt to answer questions based on the video that came out this past week about ADHD in general and about mental health more broadly. As usual, the things I'm saying are for informational purposes only, so I'm not trying not to make any specific recommendations for treatment, since I don't know your complete history or other factors that might be relevant. But hopefully this will be useful information to take back to your treatment team. I don't think there's any other announcements. So I'll summarize the video that came out this past week and then launch into the questions, which are already stacking up. So the video that came out this week was about bone health and stimulant medications. So frequently we think of bones sort of as inert, just the structure, the scaffolding or support system for what's going on. And yet at any point in time, about 5% of your bones are being actively remodeled. And so that means bone is degraded, chewed up by cells called osteoclasts, and new bone is being laid down or formed by osteoblasts. And that balance between the two can easily be pushed usually in the favor of the osteoclasts, so more destruction, and that results in osteopenia and then osteoporosis. And there are lots of studies in rodents and in laboratory cell lines showing that the stimulants can upset that balance and increase osteoclast activity and have some detrimental effect on bone growth. There's some thought that this may contribute to the observation that stimulants do have some small, and when I say small, it's less than an inch, less than about 2 centimeters in most studies, impact on expected height based on genetics for kids who are taking stimulants long-term and without interruption. There's also studies showing that if kids take a few months off each summer, then that they are able to escape the bone growth. Again, it's not clear how much of that is due to appetite changes or how much of it is due to direct bone effects. So there are dopamine receptors on both the osteoclasts and the osteoblasts, and there are different sets of dopamine receptors, and that's thought to be how stimulants may directly affect bone cells. But the bone experts still rate other classes of medications like prednisone, like proton pump inhibitors, as having a more significant clinical impact on bone health. So for most individuals, unless you have other risk factors, and there are genetics as a risk factor, age as a risk factor, it seems so far that the effect of stimulants on bone health is probably not a major one for most people. But if you're concerned, again, particularly of other risk factors, particularly if you had multiple broken bones, which seem to have occurred with undue amounts of too little stress to evoke them, then it may make sense to get a bone scan, and it may make sense to consider other medication options. The downside of that is that there are also smaller number of studies indicating that almost all of our other options, so guanfacine, completely different mode of action, Strattera, modafinil, all also can affect bone cell growth. So it's not saying, again, it's not completely clear how big an impact in the real world these are having, but at least theoretically, there's an issue there. So I'm happy to talk more about that. And that was one of the topics that was actually prompted by discussions and questions here. So I will move on to questions. Hello, Dylan. Dylan asks, what are my thoughts on pregabalin for PTSD anxiety, especially when SSRIs, SNRIs aren't effective or tolerated? Can it help with hyperarousal sleep avoidance? And as a follow-up, what are your thoughts on the concern that pregabalin gabapentin may increase dementia risk later in life? So good question. So gabapentin, which is Neurontin brand name, and pregabalin, which is Lyrica, are related GABAnoid medications. They seem to act primarily on the GABA system. not quite the same place on the receptor that alcohol and benzodiazepines do, but similarly, or not that distantly. The relationship, Lyrica and Neurontin are two different molecules. Even though it says pregabalin, that doesn't mean it's changed into gabapentin. So they are similar, but not identical. And gabapentin itself is a medication that I am leery of. So back in my training 20 years ago, it was the first psychiatric medication that I'm aware of that was slapped with multi-million-dollar fines for promoting its use in conditions that it wasn't approved for. So it was being approved or being pushed by drug reps for bipolar disorder, for anxiety conditions, and they didn't have sufficient evidence. And when they went back and did studies, for many of those conditions, it wasn't any better than placebo. So Lyrica works a little faster. It's a little more potent. It particularly seems to have more help with pain. So I've seen some people with chronic pain get relief from one or the other of these two drugs. I've certainly seen people come in for anxiety and who are already on these drugs, who are convinced that it was working for them. I think there's a large component of placebo effect with these drugs, and I've been unimpressed for most patients with how well they help with PTSD, anxiety. But I do have some people who are quite convinced that that was what really helped or worked for them. So I'd say the data is soft or squishy. They're clearly not working as potently on anxiety as the benzodiazepines do, and the benzodiazepines are not good long-term anxiety treatments for most people. I can remember with the SSRIs and SNRIs, those are slow acting, like they're antidepressant effects. And usually medications are seldom the complete answer for anxiety disorders, and usually some amount of cognitive behavioral or other therapy, exposure therapy, can be helpful in combination. So there has been at least one study that got lots of attention. I think there's been more than one study showing a link between pregabalin use and development of dementia. And one of the things that the study got most prominent use is they looked at people in the 18 to, I think, a 65-year age group. So it was not looking primarily at elderly above 65 ages, which is clearly more at risk. So even within a population of middle-aged adults who are lower risk for dementia, there was a fairly pronounced increased risk. This is only an observational study. So, but there was some dose effect. So the more prescriptions, and these were people filling gabapentin prescriptions for chronic low back pain. But the more prescriptions you filled, it seemed to be the more likely your risk for dementia increased. Now, what's difficult with an observational study is maybe back pain itself contributes to dementia. Maybe being in a chronic pain state, maybe being in a chronic pain state that affects your diet, affects your exercise, affects cardiovascular health, affects other aspects of your life, may well be the real causative factor. And again, with anxiety disorders or PTSD, those themselves may increase risk for dementia or other long-term problems. And we're not going to do controlled studies where we take 100 random people and just give them pregabalin and 100 and not, and see how many of them develop dementia 50, well, 5, 10, 50 years later. So, and although some of these studies try to control for pre-existing conditions, they're almost never thoroughly controlling for the severity of those conditions. So you might even say, oh, we looked at people who had mild back pain versus severe back pain, but those are highly subjective, and just the fact that someone was taking an added-on drug suggests that there may be more severity, either more comorbidities, or again, other confounding factors that may make that person more at risk rather than that drug itself. So I'm not a huge fan. Again, I think it does help some people, but these studies would suggest, take it as low a dose and as short a time as you can to be effective. The other thing with gabapentin itself, there's an incredibly wide range of dosages that it's commonly used at, anywhere from 100 milligrams to 3,600 milligrams, I believe, have been FDA approved. So erring on the side of less. I mean, I've certainly seen people who are over-sedated by it and groggy, slurring their speech even. So at higher doses, it can act more like alcohol or a benzodiazepine. So I haven't beat that question to death. So hello, Dennis. Dennis asks, how do I overcome procrastination when you have ADHD? So a wonderful question, and Max has already brought it up, the link to my procrastination video. So I'll summarize my plan, which I called the, what do I call it? SPAWN approach. So schedule, S, prepare, P, there's no A, W, wants, and no needs. So what I mean by that, and this is not a foolproof approach, but it's my attempt over the years to combine different techniques and things I've read about and what I've thought about. So schedule a specific time. That doesn't guarantee something's going to happen, but if you say, oh, when am I going to take care of my taxes? Oh, I'll do that later. When does later come up on your calendar or your watch? Never. It's never later yet, until it's too late. So it doesn't guarantee it if you say, okay, Saturday, I'm not excited about this, but I have time from 1 o'clock to 4 o'clock. I will work those 3 hours on my taxes. Scheduling a specific time makes it more likely you will do it. And when you're scheduling that time, think a little bit about what the task entails, what your own abilities, what your own, I mean, most people have some lull in attentiveness at siesta time, early afternoon. Probably not a good time to schedule intricate work then. If there's calls you need to make to people, you can't just decide I'm going to do it at 7 a.m. in the morning. If in their time zone, they're not going to be awake and alert and answering the phone. So think about, schedule it, but don't just randomly fling it on the schedule. Try to give yourself enough time. Try to plan a time that's going to work. Second thing is prepare. The P is prepare ahead. So you are ready to go when it's 3 o'clock. So if your plan is really that I will be working on my taxes, then you might actually need to collect all your receipts from work, or all your donations to charitable contributions, or all your whatever transactions. So you may need prep work so everything is there on hand. You might even need the forms themselves. So sometimes the prep work is so extensive that you need to schedule a separate time to do the prep work so you're ready to do the work. Other times it's pretty simple, but if you don't have it. So another example I often bring up is, say you've been avoiding, procrastinating going to the gym, and you've decided, okay, I can really go at 8 in the morning and shower at 9 and be at work by 10, and that's going to work. And you don't have your gym clothes and a lock and a towel ready to go or take with you. So you spend from 8 to 9 searching, where did I put my shoes? Where did I put my training bra? Where did I put my whatever clothes or gym equipment you need to get to the gym? You weren't ready. So prepare ahead and schedule a specific time. And then the pivot point is the W, getting in touch with the wants. So oftentimes when something's scheduled, the task comes up, and all the negatives come up. Oh, it's raining out. I don't want to go out in the rain and get to the gym and be wet before I exercise. Or, oh, it's going to be so hard. Or, oh, I don't feel awake enough. Or all the negatives usually come up first. And then even if you're trying to talk back to them, usually the response is, oh, I have to go. I should go. I need to go. I ought to go. Those may all be absolutely true, but if they were true and compelling, you'd already be doing this. They're usually not that compelling. What's more compelling usually is why you want to do it. And if you think about, oh, I like how I feel the hours after I've exercised, or I like the eye candy I see at the gym, or I like imagining having my biceps bigger or being able to see my abs or whatever it is that inspires you, that's much more motivating than I should, I need to, I have to. And often in the moment you need it most, those wants are not at the foremost part of your mind, but they're usually there when you're planning it and slapping it on the calendar. So it often helps right on the calendar itself to say, go to the gym, see your abs, or go to the gym, feel better all day, or go to the gym, whatever it is. Or if you don't have space or don't want to put it on the calendar, write that on a sticky note or take a picture of someone who has nice abs that you want to emulate, copy, put a picture of that and put it on top of the pile of your gym clothes so you see it when you need to see it. And then the end part is the no negatives. So I'm a big fan of cognitive behavioral therapy. There's lots of good, people tend to give objections to themselves, why it takes too much time or why I can't do it now. And one of the cognitive behavioral techniques is to remind yourself of the times you've done it successfully. But if you get into a discussion in your brain about why I should do it, why I can do it, going back and forth, using all those good cognitive behavioral exercises, then again, you may have consumed the hour or whatever time slot you've scheduled for this activity. I'd say it's much better, and this takes training and practice, and you'll get better with time at saying, okay, this is on my schedule. There's no other emergencies. The building isn't on fire. I'm not facing torrential flooding or earthquakes or a gunman in the hallway. I don't have a valid excuse not to do this. I'm going to do this. Now, if it turns out I didn't schedule enough time, or that this is a bad time of day or something else, or it's a bad idea to go to that gym anyway, you can revise afterwards. But the smartest, wisest, kindest part of you that's trying to align your own values with what you do in the moment is who put this on the schedule. So it's best to get into the practice of cut through the back talk. I've decided to do this. I can view it as a test or an experiment. I don't have to guarantee it's going to work, but I'm going to try this and see if it works. And then at the end of the day or the end of the week, see whether it helps or not. So that's my Spawn approach to procrastination. There is a video on it. Max has that. And there's a link to the written version on Medium with that link. So, and start that now. Don't put off. So Core Focus 26 asks, do ADHD medications, Adderall specifically, impact knee and joint pain like osteoarthritis or tendonitis? I feel that there's a correlation between taking it and increasing knee pain. So increased noradrenergic action, sympathetic nervous system, for many people does increase pain sensitivity to some extent, not universally, not significant in some people, but it's not surprising. And it's not uncommon. So yes, it can increase the experience of pain. Bodies and brains have many different ways of adapting in a good way, lessening pain over time, and some other systems increase pain sensations. So I think it probably actually helps knowing, okay, this is an added effect from my medication, and for many people, that will readjust with time and not continue to feel as bad. I mean, if there are things you're doing if your joint's already damaged, then maybe good to find an alternative exercise or something with less impact on it. So I'm not saying ignore all pain, and that's coming from someone who finished 100 marathons in my life. So Melomaniac says, I scratch my face and head after meds wear off. Takes 30 milligrams of methylphenidate. It leads to cuts all over my head and can't stop it. So I do have a video, I'm blanking on the term, it's repetitive body-oriented movements, so things like skin picking, scratching. There's not a strong connection between stimulants, but there are specific people where methylphenidate can help with those behaviors and others where it can contribute, and some people have it as a withdrawal reaction. Usually the behavioral strategies seem to be most helpful. So one is finding something else to do with your hands, including sitting with your hands or wearing gloves, or trying to be more conscious and alert about it and making it, is this an intentional action I really want to engage in? Often serotonin SSRIs can be helpful, but the goal usually is not to add another medication just to treat a side effect of a first medication, but they can help with repetitive body-oriented movements like that in some people. And there's some evidence that memantine can help as well. So that's in the video. So Melomaniac was helped a little bit by setting a specific bedtime for sleep, and that helped. So now it sounds like their sleep issue is, or maybe daytime issue too, is being in a rabbit hole about the current war, and every day I'm just into it. So a couple things, and I do have, I think it's in a video about how dealing with Trump or dealing with the modern world. So one of the things I tell people to start with is treat your media intake like a medication and get the dose that's right for you. And I believe in staying informed. I stay informed, but I think many people need to cut back on their dose of what they're consuming because it is so overwhelming. And a couple other things. One is, even though we call it news, very little of it is news, and even less of it is actionable, important news that you need to work on it. So when I say very little of it is news, one is they just repeat the same information over and over and over again. So you are not gaining new information, you are being further re-traumatized and reminded of the bad things that are happening. Two, a lot of it is commentary. So they're predicting, what will oil prices do? How is Iran going to act to this? How are the Gulf states going to act? Is India, China, Russia going to get involved? What idiotic thing is a certain US president going to do next? That's not news, that's speculation. It's good to be aware of some of the ramifications of what's going on, but again, if it's just causing stress, back out, and you don't need a dose of that. Again, it's not actionable. What's actionable is there are missiles headed towards your home right now, or there is flooding in your neighborhood, or there is a gunman loose. Those are emergencies where news can be useful. Otherwise, it's only serving an information purpose. And if that information isn't useful for you, don't partake of it, or don't partake of it that much. Again, that doesn't mean it's not important. That doesn't mean to ignore everything. That doesn't mean it's trivial. It means your own dose load has limitations. The other things I strongly recommend are reading the news instead of listening to it. So pictures are much more evocative of feelings. It's harder to think. You're prompted to react and respond. Reading allows you to stop at any time, so you are in control of the flow of it rather than getting sucked into a visual narrative. So one, you're in control. 2, your brain is processing it differently. 3, you're more able to contextualize it. So those are some of the hints or approaches that and 3, remember that for any situation out there, there are other people who support your view of what's going on. And if it helps, contributing time, money, thought, or just even hanging out in a support group and letting people know you know and care is doing something that, even if you don't have money or time to donate, can help you feel part of a bigger cause that is helping you feel connected to people in a positive way and helping you feel more fulfilled and good about things. So that's important, big issues right now, and hopefully some of what I said is helpful. Hello, Kumail, did I just miss? Okay, I did miss. So Javier, hello, has any thoughts on interactions between Adderall and Cymbalta? So both of them have benefits for ADHD. Cymbalta also has some benefits for depression, benefits for anxiety disorders. To some extent, they're overlapping a bit. So they both have norepinephrine reuptake action. So if you're adding one to the other, there's some potential for feeling more revved up, more overstimulated than you might from before adding the second agent. So add it slowly and carefully. That's an advantage for some people because it means they can get away with a lower dose of the stimulant when Cymbalta is on board. Again, the Cymbalta duloxetine can add an anti-anxiety component. So in terms of other things like cardiovascular effects, they both have the potential to increase heart rate and blood pressure, and the two together make it more likely. So I'm not aware of any sort of multiplicative or hugely synergistic effects. Most of the effects I'm aware of are sort of additive, that you're having two agents there then that might be banging away on norepinephrine reuptake. So I've had numerous people, because for years again, no risk of addiction, no risk of psychosis with Cymbalta. So many people are more comfortable starting with that and then adding on a lower, smaller dose of Adderall if the Cymbalta alone hasn't been sufficient enough for treating ADHD. So Kumail, Jawadi, I should put on my glasses probably, is a 33-year-old software engineer, a husband, father of 2 young children. Already, that's a lot going on. I've never been formally diagnosed, but I've long struggled with inattention, restlessness, constant mental noise, task inconsistency, unfinished projects, and anxiety around routine tasks. I'm a perfectionist with high standards and a tendency to overanalyze, which often leads to paralysis. There's a strong multi-generational pattern. Mother displays similar traits, and 7-year-old son is hyperactive, easily distracted, despite being very smart. We've noticed a pattern of ADHD. So now the question, how should I start the diagnostic process for myself and for my son to get clarity and begin managing this effectively? So it sounds like there's good reason to consider that ADHD is an important diagnostic question. I mean, there could be anxiety disorders mixed in. We know there are some genetic components to perfectionism. I do have a video on perfectionism on this channel, as well as multiple ones on ADHD. The starting point, depending on what your health insurance coverage and local availability is, would be an evaluation by a psychiatrist, and starting with describing, this is the pattern of things I've seen. These are the aspects that are problematic in my life. And the gold standard currently for an ADHD diagnosis is a clinical evaluation by someone familiar with ADHD. And that's what every single professional medical organization says. So is there pen and paper testing or now computerized testing that can ask some of those questions like, do you get distracted? You're often late for events, blah, 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 blah. Things like the Conners or other ADHD rating scales. Those can be supportive of a diagnosis, but they don't definitively diagnose this condition or any other condition. There are also neuropsych testing where we can measure things like attention span and delayed impulse control and other cognitive executive function abilities. And again, those don't definitively tell you whether you have ADHD or not, because conditions like depression or anxiety can also impair executive functions. But so usually those additional forms of testing are not needed and expensive. And in some scenarios, people routinely order them. That doesn't usually seem necessary. So it's an evaluation of looking at what your symptoms are and looking at what makes them better or worse and looking at their pattern over time. So again, it's not just symptom checklists. If you want, you can find dozens of symptom checklists for ADHD. Most of them are based on the 18 points of the DSM criteria, which are themselves probably not the ideal set of symptom criteria. And that can give you a strong suggestion. But those are screening tools, and all screening tool says is there's enough here to merit further evaluation. So that's how I would suggest getting started. So I'm checking to see if I've skipped anything, because some of those questions were interweaving and skipping around. Okay, you're welcome, Dennis. So Dennis has another question. His general practitioner said that methylphenidate is a proamphetamine. Does this mean it gets transformed by the body into amphetamine? In the simple, ecstasy is a proamphetamine. So MDMA is a proamphetamine. Ecstasy does get broken down and transformed into amphetamine. To my knowledge, there's no metabolic, so methylphenidate and amphetamine are cousins. There is some structural similarity, but I am not aware of biochemical pathways that convert methylphenidate into amphetamine, and I can say that even if there are some that might, it's an extremely small and minor fraction or pathway that's not generally followed. That's how I would answer that based on what I think I know. So thanks, Max, for providing the link to the body-focused repetitive behaviors. Thanks, that's the term. So Philip, this is off topic, but our whole topic is life and mental health, so probably won't be. But I just want to say I started Lamictal, 25 milligrams a couple of days ago, ADHD and autism. Task initiation and analysis paralysis has improved so much, and also porn addiction. So I'm glad it's helpful. Lamictal or lamotrigine is initially a seizure medicine. It certainly is effective for bipolar disorder, particularly the depressive element of it. And real world data on ADHD is extremely limited. I do have a talk on that. And I think Max is finding it right now. I think at least one other person reported a pretty dramatic and on a fairly low dose. So usually with Lamictal, the target dose usually in bipolar disorder is 200 milligrams. When it's used as an anti-seizure agent, it's usually 200 to 300. But because it has a chance of causing Stevens-Johnson and other really dangerous rashes. We know that that risk is lower if you titrate up. And my thought is if you're getting good responses at a low dose, then it makes sense to stay at the low dose and see what it's doing even longer before necessarily pushing higher. So thanks, Max. So the videos on coping with Trump are current events. And again, you don't have to be in the US. You don't need to be, although he's inflicting misery throughout the world. It's more a strategy of how do you interact with the media and ways and current events in the world in ways that help keep you sane. So Felipe or Philip or some other pronunciation that I'm butchering started the Lamictal after numerous failed antidepressant trials for bipolar depression and panic attacks, with which this medication suffered more compared to SSRI. Side effects profiles much better. Yeah, it's hard to know how do you evaluate a risk that's deadly serious but really rare. And the other really confusing thing with Lamictal, the commonest side effect that I've seen clinically and in most of the studies comes out, is about 10 to 15% of people have rashes. Almost all of those rashes, 99%, are going to be benign, not serious. But even dermatologists, particularly in the early stages of a rash, can have trouble identifying what kind of rash this is going to develop into. And people have died from taking Lamictal from the rashes, from the Stephen Johnson, and there's some related rash conditions in the same family. So yeah, so I don't fault people for saying I'm leery of that medication, even though the other message that the side effect profile, other than the rashes initially, and again, most people that's short term, it's not usually chronic rashes. My experience with most people who are taking Lamictal is they say, I can't tell I'm taking it at all. I'm not feeling drugged. I'm not feeling sluggish. I don't have aches or pains anywhere. I'm not having gastrointestinal side effects. All I've been able to tell is over time, I'm having no depressive episodes or no bipolar episodes. So, and with SSRIs, the majority of people don't have side effects, but particularly in America where people often wind up on doses bigger than they need, some people do feel sluggish. Sexual side effects are third to a quarter of a time. Gastrointestinal effects, a third to a quarter of a time. Usually that's short term. Some people do have mood flattening. The majority of people on SSRIs also, particularly compared to the older tricyclics, SSRIs have a wonderfully better side effect profile. But they do have some side effects. So, Hanshin, hello again. Given that phenylalanine is a precursor to dopamine, is there any evidence suggesting it being effective for ADHD? So I am not aware of any, I'm not aware of formal testing on it. And so often, and I do have a talk on this, that taking precursors of neurotransmitters very seldom results in boosting levels of neurotransmitters. And part of that is it may not all get absorbed, it might get digested, it might not get delivered to the brain, it might not get delivered to the cells in the brain where you want it to go. And even if you get it there, unless a limit of phenylalanine is the rate limiting step in making enough dopamine, now that's presuming the problem is that you're not making enough dopamine, then it's not going to do much good. So I use the analogy all the time of if it's a car manufacturing plant and you want to churn out more cars off the assembly line. And the rear bumper is an essential part. So it's absolutely vital to the car. You need it. You can't have cars coming off. So, hey, I got a whole surplus of new rear bumpers. I'm going to bring them into the assembly line, and that's not going to make your cars churn out faster unless it was a shortage of bumpers, rear bumpers, that was slowing down your assembly line. So I can look into it, but I'm not, and particularly lots of people are into precursors and supplements rather than medications. I can see their attractiveness. So the next question Hanshin had was, what are my thoughts on Mydayis? So Mydayis is a long-acting form of amphetamine salts. It's a slow release or long delayed mixture. It is, to my knowledge, the longest coverage during the day. So I've had people who had a good and positive response to Vyvanse, but they felt it only worked for them for 12 hours or so, 12 to 14. I've had people who took a Vyvanse early morning and then a Vyvanse at 11, so that could sort of extend the profile of taking it. But I've also had several people who preferred Mydayis, which for many people works closer to 14, 15, 16-hour framework. So if you have a very busy day, and I'm not making a specific recommendation, but if you had taking care of two kids and a busy work life and other things where you needed to be functioning at a high level throughout that time. So I've had some people who like Mydayis. Now, Mydayis is still a branded product in the US and will be for many more years. So it's considerably more expensive if you have to pay out of pocket. I've had it covered when we explained what other things we tried that last a shorter amount of time. So I think it's one of the few, and we have well over, I think it's closer to 20 than a dozen different variations on methylphenidate and amphetamine products, which tweak the ratio of dextro to levo forms and have some different patterns of slow release forms. And my assessment of most of them, I think there's given individuals who might deal optimally with any of those, but most of them are making such subtle tweaks that for most people, they won't notice any difference between Vocalin and Concerta and generic Ritalin long-acting. So they're chasing a market by their marketing gimmicks rather than real innovations. I'd say Mydayis, because it does last longer, that's a real niche. I'd say Jornay, because you can take it the night before, not have any drug delivery during the night, and work in the morning. That is a real difference than the other things out there. So that's my take on that. So thanks, Max, for providing the link to, things are jumping around now, view on Lamictal and a video on perfectionism. So Philippe recommends the QB test for diagnosis. Acetylcholine 2026 are the muscles of the mouth controlled by the somatic nervous system. Does this mean they rely mostly on acetylcholine to function? So I'm going to pass on some of my, the non-smooth muscles. So there's smooth muscles in the walls of blood vessels, smooth walls in some of the organs, but our skeletal muscles, and this is a skeletal muscle, do use acetylcholine as the neurotransmitter, separate from whether they're powered by nerve roots coming off the spinal column or cranial nerves. So the skeletal muscles around the mouth do use acetylcholine. So again, thanks, Max, for the link on Lamictal. Could choline supplementation help someone to overcome stuttering? So my answer usually is anything is possible, and a given individual can respond in any way to any substance. I'm not aware of choline being used systematically to treat or help with stuttering. I do have a video on acetylcholine and choline supplementation. Yeah, there's more evidence of it helping or that supplements can do something for muscles than that they can do for brain, but there may be some brain impact from taking choline. So Christopher asks, what are the best supplements to take with Adderall or stimulant use? Magnesium, what are my thoughts on creatine? So I do believe I have a video on creatine. I've certainly seen some people, and there is some research data that magnesium can be helpful. There's dozens and dozens of supplements out there, and it's not that they clearly don't work. It's that many of them have a little bit of data. There's a few studies on saffron. There's a few studies on lion's mane. There's a few studies that look like they may be effective, but almost none of them reach the level of that I would recommend to anybody or everyone. And most of these are generally safe, and many of them have plausible mechanisms by which they could help with ADHD. So I think magnesium has some good research basis. I think there's some for fish oil, although there have been some negative studies as well for fish oil. I haven't had patients report to me any marked benefits from creatine. So Philippe was on Lexapro for 1.5 years and made his ADHD worse, had sexual side effects, emotional blunting, and weight gain caused by overeating. Before tried Remeron, Wellbutrin, Strattera. So weight gain is not a common side effect with Lexapro. I know the manufacturers of Vyvanse would promote for overeating disorders. I mean, yeah, I guess so. Boosting neurotransmitters, Max has a link to that. So jumping back to Philippe's, Wellbutrin sent me on a manic episode with psychosis plus an allergic reaction, had very bad hives all over legs, felt depressed after that, and panic started that. And providers suspect Wellbutrin unmasked a bipolar disorder, haven't been feeling the same since, other than antidepressant trials now and again after almost 2 years, Lamictal. I'm getting out of the depression. So I'm glad Lamictal's helping, and it sounds like you've been through quite an ordeal. And unfortunately, and it's not just psychiatry that much of it is trial and error. One of the most common problems, hypertension. We have dozens of hypertensive agents from a number of distinct mode of action classes, and sometimes there's 1 or 2 good choices to start with, but usually it's just we are guessing and seeing what works and what isn't causing side effects. And hopefully, as we learn more about the body and the brain, we'll have more targeted, specific treatments that we know are likely to work. So embedded in there, so XO7499 reports that Mydayis is hard to find in the US. It's interesting because at least I've only had a handful of people on it, but in general, they were not having problems filling it when there were shortages of other amphetamine products in the US market. But it's not unusual to think that the Bay Area, San Francisco, may have a higher demand or there may be more usage of it, so pharmacies may be better in tracking it and filling it. So Max asks, is bupropion or Ritalin often paired with venlafaxine? So venlafaxine in the US was the first SNRI, serotonin and norepinephrine reuptake inhibitor on the market. And when that was so, I used it often for ADHD, because again, it's clearly doing something beyond what SSRIs can do, and the norepinephrine action can help. But it's really pretty darn weak on the norepinephrine end of things, much weaker than compared to duloxetine. At doses below 100 milligrams, it's virtually an SSRI. So it is often paired with bupropion or Ritalin with that regard. Again, at a higher level, it is bringing in norepinephrine action, so it may be duplicative. My thought, so in my practice, I've used them together. And I think much more widely outside of my practice. And again, part of it is I'd much more commonly use duloxetine alone, or even milnacipran, Savella, or Fatsima. So hopefully with one agent, instead of duplicating venlafaxine plus bupropion or Ritalin plus venlafaxine, you could take care of the two together. The other reason venlafaxine I've downgraded in my options when other SNRIs became available is that of all our antidepressants, it's one of the two, with Paxil being the other, clearly most tied to withdrawal, bad SSRI withdrawal reactions. And people often feel lousy if they miss just a day's dose, and it can be intense nausea, it can be sudden crying episodes, it can be panic attacks. And there's many people, given its short half-life, who actually every day are having some amount of withdrawal until they take their daily dose. So it can happen in less than 24 hours. So it works well for many people. For years, I used it a lot, but it's not at the top of my options now. Pix Pusha says, the kids I see who have been on stimulants are far shorter than what the pharmaceutical company led people to believe. So I would say it's not just the pharmaceutical companies. There are independent researchers and studies that have looked at this, huge numbers of people, thousands and thousands. And again, on average, it's less than 2 centimeters. So it's not. What I will say is that I do think there's other factors. So I had 3 different individuals, all males, all of Jewish Ashkenazi, 2 of them Russian Jewish heritage. So these were guys who are now in their 70s or dead, who all had severe ADHD. They grew up in an era where they were not treated with any medications whatsoever, but a huge theme of part of the psychotherapy, or a recurrent theme, was each of these guys was 6 to 9 inches shorter than their dad. So they felt defective because of their ADD, they felt defective because of their height. And again, these individuals were markedly shorter than their male relatives and father, and it clearly was not the result of medication. So one is, even though there's a strong heritable component to height, there are other factors at play, and some kids will be markedly shorter than their parents, and some will be markedly taller. I mean, my husband's a good example in terms of height. So he's 5'5", and his younger brother is 6'1". Same biological parents, huge discrepancy in height. So when we have small sample sizes, it's hard to make conclusions, but so there is a real impact on height, but on average, it is not a huge one. And again, at least with methylphenidate and summer breaks, that seems to completely allow people to escape from the height effect. So core focus 26. Does Adderall cause any sexual function side effects? I read that loss of interest can happen, but what about any physical side effects? And are general side effects well studied in adults 45 years and older? So one is sexual performance in males and females is an intricate balance between parasympathetic and sympathetic nervous system. So unlike the old tricyclics, which often caused erectile difficulties, or unlike the SSRIs, which often cause orgasmic delay or inability to achieve orgasm, in general, sexual side effects are not as common among Adderall and other stimulants, but they're not, it's not particularly rare. I mean, what's hard to sort out is stimulants certainly can affect motivational states, and it can affect attention and focus. So I've certainly had some people who felt less interested or motivated. I've had, so the other thing with feedback loops, with once you've had a lousy sexual experience, that doesn't certainly have to contribute to feedback loops based on expectation, based on worry, based on being judged, based on confidence in your own performance. So, I mean, interesting, when people have sexual side effects from SSRIs, when you treat them with Wellbutrin, or you treat them with, I mean, often methylphenidate can actually help alleviate SSRI-induced sexual side effects. Not always, but so Wellbutrin is a standard accepted treatment for the sexual side effects. It works about 2/3 of the time, but placebo works more than 1/3 of the time. So that's saying a huge proportion of ongoing problematic sexual side effects seem to be alleviated by taking something that you believe is going to alleviate them. So that's what I can say. I mean, in general, sexual side effects are not extensively studied unless a drug's already been shown to cause problems in that regard, or unless the drug company thinks they can market something as being dramatically better in that regard. So thanks, and Max is pointing out one of the useful things he's helped create. So on the playlist of videos, there's actually a list of videos related to different supplements that I've covered. So if there's some that you particularly want me to cover that I haven't yet, let me know and I can try to do that. So acetylcholine 2026 says, in my Medium article about vitamin B9, you said that the MTHFR gene, so that's the one that helps process folate into methylfolate and make it an active agent in the body, is particularly common. So that genetic component is particularly common in Latinos. Why is that? So I haven't seen a compelling or good explanation. So I would say I would just leave it at the level of observation. We know that different populations have different representation of certain alleles of certain variants of certain genes, and we can make up stories as to why that can be. So, we have stories about why thalassemia and other sickle cell genes, which increase resistance to malaria, were preferentially valuable to populations in high malarial risk areas and are less useful maybe in today's modern world. So I don't know, but some genetic variants just get perpetuated because there's bottlenecks in the population or founding effects of who started there and what. So we often come up with evolutionary stories which are hard to refute or test, even though some of them make lots of good sense. And I'd say in general, the MTHFR variant doesn't seem variants of slowly processing if you have high folate population. If your diet's rich in folate, if you're getting a lot of the basic ingredient, it may matter less that you have less efficiency in converting it because you're getting so much anyway. The low conversion rate still gives you enough. So it may be that where this population was originating, their diets were so rich in folate that it didn't matter. So in the article, I also talked about anteaters. I think cats and anteaters are some of the species that have actually no effective MTHFR, but at least I think I'm getting this right. Maybe I'm mixing different supplements. But if their native diet has enough of it, so much of it that they can get away with only converting a little, they're okay. I'll end it there. So Core Focus 26 has started Adderall about 3 months ago. It helps, but it's not been a miracle drug, as some people report. How do I think about whether to try a different drug? Started 5 milligram, moved up to 20 milligram, 5 milligrams each month. So every study I'm aware of indicates that more than 90–95% of what you will get from a stimulant like Adderall or methylphenidate, you get the day you take it. Now, there is day-to-day fluctuation in most people's behavior, and therefore potentially response to a drug. I don't see any purpose in sitting a whole month at 5 milligrams. There's no purpose for that slow titration. That's just wasting people's time. And I do have a talk about high doses. Rather than focusing on how many milligrams, if you are having some effect, which sounds like you've had, and there seems to be room for more, it makes sense, and you are not having side effects. For most people, and this is my philosophy, and apparently others have different philosophies, it makes sense to keep going up. And not focus on what the number is, but focus on, am I getting benefit? Am I free of side effects? Go up. And again, with the stimulants, you know that usually within a day, but to confirm it within 2, 3, 4 days. So going up more rapidly and getting at an optimal dose more quickly makes sense. And I would absolutely push a medication you've already started and are already tolerating higher before jumping to a different agent. That's what makes sense to me. I can discuss that philosophy more. I see I'm actually running out of time, so I'm going to kind of race through. So I do have some talk on iron. I don't know that Vyvanse would be any differently affected than other forms of amphetamine. So I do have a talk on iron, so I'll refer to that. So acetylcholine is mentioning that they've seen people with a lot of height variation in ADHD families. Max provides the link on iron and ADHD. Thanks. So acetylcholine is following up on lots of height variability in ADHD families. So I'm going to probably just collect the remaining ideas to comment on later, unless they're really quick. Watson is in ADHD patients who become panic sensitive after a stress event. You think the issue is locus coeruleus dysregulation or epinephrine signaling? Would you stabilize that before reintroducing stimulants? Yeah, I mean, some of it, when you say panic sensitive, is how quickly or how frequently they're having panic. And cognitive behavioral therapies for panic are tremendously effective and do result in changes in neurochemistry when they're effective. And I've seen lots of people who become convinced that they have some toxic reaction to the medication when what they're really having is a panic attack induced by the medication. And that's a very different thing, because a panic attack can be unlearned. If it's really a toxic response of your body, then that should be harder to unlearn. So Luke asks, what about methylated B6 and folic acid for ADHD? Is methylated vitamins mostly a selling gimmick? So I do have a video on folate. I mean, with folic acid itself is not active in the body. There's 2 steps, and I'm blanking on where it becomes L-methylfolate. So the methylfolate is the active form. So in that case, folic acid, there really is a distinction. Again, most people's bodies can convert the folate to L-methylfolate, but some who have a weak or inactive version of the enzyme, the MTHFR form, can't. But with other vitamins, methylation may be irrelevant or not as important. Luke, do I think that dissociative agents such as esketamine or dextromethorphan have any promise in ADHD? Psychedelic treatment even interesting, especially in comorbid ADHD? I'd say potentially not a lot of data. Max did provide the ketamine link, so that addresses some of it. Hamid asks how to deal with insomnia caused by Vyvanse. One is lower dosage earlier in the morning. I mean, a strange phenomenon that I've seen dozens and dozens of times over the years is often just moving a stimulant to an hour earlier, which you'd think that should just have a minimal effect at the end of the day, can often be enough to allow it. I would use techniques like cyclic sighing that hopefully can reexert a parasympathetic balance over a sympathetic balance. Another might be reducing the dose, because Vyvanse, particularly going higher on the dose, has a bigger impact on extending the half-life, how long it's lasting. Yeah, so anxiety. So during COVID, I mean, several of my patients who had been stable on a dose of a stimulant for years needed to back down on the dose. So an external situation driving anxiety and or panic can, again, largely because it's pushing or ratcheting up sympathetic overdrive, can be a compelling reason to downgrade or decrease dosage of a stimulant. So thanks for being here. Thanks for the good questions. Let others know about it. I'm glad to be here, and hopefully this is helpful and informative. See you next week. Stay healthy and happy, and being upset about what's going on in the world is a sane response to a crazy world right now.